why is it important to have specific practical guidelines on HIV lymphomas?
Yeah, as I said, the incidence is decreasing, but the incidence is 4 to 20-fold higher than in general lymphoma population. And what is also important is that the most frequent type of cancer in people living with HIV are the lymphomas. And lymphomas contribute to a significant morbidity and mortality for these patients. And the mortality rate for lymphomas is higher than for opportunistic infections. And so there is a good reason to take care of these patients.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am your host, Isabel Olivera. We are here today with Professor Kai Hubel. Can you please introduce yourself?
Yeah, my name is Kai Hubel. I'm a hematologist and oncologist from the University Hospital of Cologne in Germany. I'm practicing now since more than 30 years. My scientific interests focusing on lymphoid neoplasia, including HIV-associated lymphomas, and I'm also sharing the European Network for HIV-associated Lymphomas, which was founded last year. It is part of the EHA Lymphoma Working Party, and we have now around 25 members, which is really great.
We're here to discuss the EHA ESMO clinical practice guidelines on HIV-associated lymphomas. So can you explain first what your involvement on these guidelines was?
Let me say it was a great experience to develop such a guideline. I never thought that it needs more than 2 or 2.5 years from the very beginning until getting the guideline published. The first challenge was to gather a group of very experienced investigators from different European countries. And the second challenge was to find a consensus on the guideline, because I really learned that HIV lymphomas are treated differently in different European countries, and we have to find a consensus. But finally, we got it published. I think it was in the summer last year.
So why is it important to have specific practical guidelines on HIV lymphomas?
Yeah, if you see the incidence of HIV-associated lymphomas, the incidence is decreasing since the beginning of the century, mainly because of the introduction of the modern or combined antiretroviral therapy, the CART. So this is a good question. Why do we need a guideline? But there are several reasons. First, the outcome of HIV-associated lymphomas is different or is worse than for non-HIV-associated lymphomas. For example, if you have a Burkitt lymphoma, you can treat patients with a very intensive protocol. But if the patient has HIV, a Burkitt lymphoma, then there's a high rate of fatalities of around 10%. So we need different treatment approaches. Another reason is that the concomitant therapies are different between HIV and non-HIV associated lymphomas. Another reason is that there are rare lymphomas, more or less exclusively developing in people living with HIV, for example, the primary infusion lymphomas, and we need guidelines, recommendations for these patients. And finally, we have a lot of modern treatment approaches like the T-cell-directed therapies. And of course, we need a recommendation. Can we use these therapies in HIV-infected patients?
You touched a bit on this, but how prevalent are HIV-associated lymphomas?
Yeah, as I said before, the incidence is decreasing, but the incidence is 4 to 20-fold higher than in general lymphoma population. And what is also important is that the most frequent type of cancer in people living with HIV are the lymphomas. And lymphomas contribute to a significant morbidity and mortality for these patients. And the mortality rate for lymphomas is higher than for opportunistic infections. And so there is a good reason to take care of these patients.
Which are the most common histological types of HIV-associated lymphomas?
The most frequent HIV-associated lymphomas are the diffuse large B-cell lymphomas. It accounts for about 36 to 37%, followed by the Hodgkin's lymphomas with a rate of 26%, and the Burkitt lymphomas with a rate of 20%.
Is the prevalence the same as lymphomas that are not associated to HIV?
It's nearly the same for the diffuse large B-cell lymphoma, but it's not the same for the Burkitt lymphoma. It's more frequent. And what we rarely see in HIV-infected patients is the indolent lymphomas. And we only see rare CNS lymphomas, mainly because of the CART.
What are the main challenges in diagnosing HIV-associated lymphomas? How do you combine the procedures for the diagnosis of lymphomas with the procedures to assess HIV?
Let me say, in general, we can use the same diagnostic procedures as we use in non-HIV-associated lymphomas. But, for example, there's an ongoing discussion about the PET-CT scan, because if you use a PET-CT in patients with HIV infections, then you may have a high rate of false positive results, mainly due to overlapping infections or due to immune dysregulations, which lead to an hyperplasia of the lymph nodes. So be careful if you use a PET-CT scan. And we often have a situation that the diagnosis of the HIV infection and the diagnosis of the lymphoma is at the same time. And in this situation, you have to follow for the HIV infections the recommendation for newly diagnosed HIV infections.
How do you combine the antiretroviral treatment for HIV with the lymphoma treatments?
This is a very important question. And there was consensus in the guideline that there is no reason to stop the CR, the antiretroviral therapy, during the lymphoma treatment. Sometimes investigators are a little bit uncertain to continue the CR during lymphoma treatment because of maybe interactions, but there is no reason to stop it. Also, if you use a high-dose chemotherapy or an autologous transplantation or a CAR T-cell therapy, does this mean that there is no interaction? No. There could be an interaction between the retroviral therapy and the lymphoma treatment. So if you are unfamiliar with this, you have to ask a HIV specialist, or you can visit websites who may help you. But again, no reason to stop the antiretroviral therapy.
Is it dangerous to stop it?
It's a very important part of the lymphoma therapy. We know that since we have the modern antiretroviral therapy available, the prognosis is much better for the patients.
How do you manage the increased risk of infections on HIV lymphoma patients?
Well, if the patient has a good immune system, let me say in CD4 cell count of more than 200, you can follow the same recommendation as for the HIV negative patients. However, if the cell count is less than 200, we recommend a general PCP prophylaxis, and we also recommend an antiviral prophylaxis, especially if the patient has a history of a viral infection. And if the patient has a CD4 cell count less than 100, we recommend a CMV monitoring and also a mucosal and candidiasis prophylaxis. So this is a little bit different from the HIV-negative lymphomas. It depends a little bit on the CD4 cell counts. This is important.
So what are the key differences for you in treating an HIV-positive versus an HIV-negative lymphoma?
So let me say, in most situations, we can use the same therapies for the HIV-positive and HIV-negative lymphomas. But there are some differences. I will give you some examples. First, the use of rituximab. Rituximab significantly improves the overall outcome of patients with B-cell lymphomas. And this was also shown for the HIV-associated lymphomas. However, we know from randomized trials that if the patient has a CD4 cell count less than 50 and you use rituximab, then you have a higher rate of fatal infections. So there's a general recommendation to be careful with the use of rituximab if the CD4 cell count is less than 50. Another point, CAR T-cells. I know in different European countries, CAR T-cells are not allowed in HIV lymphomas. And the data are rare, but we know from several case reports and we know from one clinical trial, including nearly 30 patients, CAR T-cells are visible in HIV lymphomas. So we gave the recommendation, if the patient has a CD4 cell count of more than 200, then you can use the CAR T-cells if it's in label. And I will briefly focus on the Burkitt lymphoma. I said at the very beginning that we have a higher fatality rate if we use an intensive regimen in HIV Burkitt lymphoma. So if the patient is in a good condition, you may use, of course, an intensive protocol like the German GMAT protocol or the mCODOX IVAC protocol. However, if the patient has comorbidities, then you should not use these intensive protocols. We recommend to use something like dose-adjusted epoch R. The results are great for Burkitt, HIV Burkitt lymphomas, but, and this is also important, only if the patient has no CNS involvement and has no bone marrow involvement. And we also give, as I said at the beginning, we give recommendations for rare lymphomas like the plasmablastic lymphomas or the primary fusion lymphomas.
So we would like to highlight that in these AHA guidelines, there are specific and detailed recommendations for DLBCL, for Burkitt's lymphoma, for plasmablastic lymphoma, for primary effusion lymphoma, for CNS lymphoma, primary and secondaries, for Hodgkin's lymphoma, and more. We cannot summarize everything in this podcast, of course, so please check the full details in the paper in Hemisphere. The full link will be in the description. Is there anything else that we haven't touched on that you would like to add for the audience about these guidelines?
I would like to close this interview with a call, because it's so important that we get more data on HIV lymphomas. So it is very important to open clinical trials for HIV, for patients with HIV lymphomas. In general, it's an exclusion criterion to have an HIV infection. So I don't understand why. Please open clinical trials for HIV lymphomas. And second, to get more data, it is necessary to have a registry. And we have a European registry, which is chaired by my colleague Markus Hendrich in Munich. And so if you treat patients with HIV lymphomas, please send us an email or call us, and we will try to include your patients in the registry.
Thank you very much, Professor Hubel, for being with us today.
It was my pleasure.
And thank you to the audience for listening. And if you enjoyed this episode, please like it and subscribe to our channel. Stay tuned for more episodes of EHA Unplugged.